Thank you. Welcome to our Alumni Spotlight Lecture featuring Dr. Thomas Marxen. These lectures have become a tradition during homecoming and reunion weekend, and we are delighted to have Dr. Marxen join us today. Dr. Thomas O. Marxen is a periodontal prosthodontic specialist and cosmetic dentist practicing in Woodinville, Washington. Dr. Marxen currently teaches seminars and continuing education classes at the University of Washington School of Dentistry. He is a certified instructor for the American Dental Association and has authored nationally published articles about cosmetic dentistry. In 2019, Dr. Marxen presented a periodontic case study before the University of Washington Graduate Prosthodontic Alumni Association. In addition, Dr. Marxen was selected as one of America's best dentists 17 times, including each of the last 5 years. Dr. Marxen earned his Doctor of Dental Surgery from Case Western Reserve University in 1983, where he taught prosthodontics as a dental student. Afterwards, he completed his Master of Science in Dentistry in a field of cosmetic reconstruction of gingiva and teeth, with a specialty certificate in periodontal prosthodontics from the University of Washington in Seattle. Please join me in welcoming Dr. Thomas Marxen as he presents Dental Infections Can Kill You, Periodontal Infection Control, Case Studies and Insights. Dr. Marxen.
Thank you. Do we have like hecklers in the back row too? Maybe? In the front row. Can we have some fun this afternoon? You could be doing a lot of other things rather than be here. But let's have some fun. Like, for instance, be nice to your classmates because you never know. Like, for instance, my son is dating the daughter of one of my classmates. I'm in Seattle. He's now practicing in Fort Lauderdale. They meet online, and one says, "Oh, my dad's a dentist too." But I think they're probably going to get married. But anyway, so be nice to your classmates. You never know. But again, thanks for coming. Friends that know me I will say just random things, and I can get off the trail. This is a disclaimer, okay? I can get off the trail, hopefully not down a rabbit hole, but at least I've got these 2 pointers to help me get to the point. And this one doesn't work. Anyway, one's red, one's green. I'm hoping you want the green one more. Well, that's red. Well, too bad. But anyway, without these pointers, this whole presentation would be pointless. Okay, in my own mind, some of you laughed, and I am standing up, so I guess that makes me a stand-up comedian. Right? Oh. Okay, all right, that's enough. Okay, the forward button. There we go. This is Lake Sammamish on the east side of Seattle, and at the north end of this lake is a beautiful water ski course. And when I was in Ohio, I used to do a lot of water skiing on Lake Erie. As a matter of fact, in high school, I did a nonstop, completely all the way across the lake. I started at Catawba Island, and I let go of the rope before the mouth of the Detroit River. Why did I let go? Because I didn't want to set any records in Michigan. Okay? But anyway, back to the water ski course. I was rounding the buoy, and you're looking on the horizon. You're not looking where you're going, because then you're going to miss the buoy. But I crashed into this big wakeboard wake. You know those surfing wakes, how big they are? Yeah. So I flipped in the air. I did a complete flip. If I had landed on my head, I'd have broken my neck. But I landed on my back. I fractured 7 ribs, 2 in 2 places. 1 punctured my lung, tension pneumothorax. Fortunately, it was right before COVID. I'm in the hospital with a chest tube for 3 days. No one was. There was somebody that coughed down the hall. I said, "Would you please shut the door?" You know, because it hurts to breathe, let alone if you had to cough. But anyway, you know, I do enjoy sunsets. That's pretty cool, huh? How about that one? That one? What about that one? Not that bad, huh? But another nice one. But I'm on a hike this summer. You thought you were going to hear about teeth, right? So I'm on a hike this summer, and I'm at 6,500 feet. I'm going up to a lake. I got 35 pounds on my back to fish in this trout lake in Eastern Washington. But I got off the trail. I gave you a heads up in the beginning, right? I got off the trail. I ended up going down the mountain with this backpack on, and then oh crap, I'm off the trail. But you know what? You have to make the best of things. I didn't whine. I just looked out in the horizon. You know what I saw? I saw Dr. Twardowski's sculpture that's outside of the old dental school. Is that amazing? Here it is. Beautifully framed by the mountain peaks here, and then the clouds give the sculpture some depth. But that's it, right? Has anybody seen the sculpture that he did? Okay, well, anyway, so it's in Eastern Washington. Okay, so now to our topic, dental inflammation. Now, how many in the room, I'd like this to be interactive, is that okay? Okay, how many in the room, raise your hand, if you feel like inflammation can be unhealthy? Raise your hand. Perfect. Okay, how many in the room have experienced or known someone that's died from a dental infection? Raise your hand. That's not very many. You know what? To me, that proves that there's a big wall between dentistry and medicine. And then being from Seattle, I'm for open borders, summer love. But I feel at Case Western Reserve, the wall's smaller, or there's holes in it. And there's a better chance for collaboration. A better chance. Why is there a better chance for collaboration? Why is there a better chance for Because we have Dean Chance. Yay! Okay. But no, actually that and the fact that we're all under one roof. The medical school, the dental school. He's laughing. I like that. Thank you. The dental school, the medical school, the nursing school, much better ability to collaborate versus other schools. So back to our topic. So I feel, and this is a personal opinion, that a lot of our people in healthcare, they think the blood has a brain. When it goes up to the head, it says, oh, that's just a dental infection. We don't have to worry about that. We only have to worry about a bladder infection, kidney infection. When you're making dinner at night, you accidentally cut your finger, fibrin blood clot forms, the body's amazing ability to heal itself. You know, when blood sees inflammation, it wants to clot, right? What's it called when it clots up here? A stroke? What's it called when it clots down here, right? And myocardial infarct, an MI, a heart attack, right? When blood sees inflammation, it wants to clot. And I think we have to educate our colleagues about this basic information. I'd like to dumb down Periodontology 101 this afternoon, and I'd like to dumb down Dental Anatomy 101 that we learned from Dr. J. Yes, Dr. Yes, I Am Vicious. Man, did I have a crush on her in dental school. Oh, man, there you go. I told you, I'd say random things. Yes. But lastly, I want to talk about 8 cases. the first 7 becoming overwhelmed with inflammation, pus, infection, and then the 8th patient, we controlled the inflammation. And I mentioned that word pus because that's what people can relate to. Years ago, my hygienist, they would say, oh, there's a little puffiness, there's a little redness, there's a little swelling, there's a little inflammation there. For most people, that means nothing, right? If you mention the word pus, they get it. What's the subject that's searched on YouTube, the #1 subject? What is it? It deals with pus. And who's famous? Dr. Pimple Popper, right? So we're going to start out now with Periodontology 101. Do you guys have one of these? You're supposed to pick one up in the beginning. Stick with it. Okay, so the 8th case where we controlled inflammation was published here, Journal of Multidisciplinary Care. It's a pretty good journal, a lot of good articles, except for the one that I published in general on multiple disciplines of dentistry. I can't badmouth it too bad because my son helped edit it. But Periodontology 101. Okay, so in the issue where I published, it has a beautiful cross-section of this tooth. So around the tooth is the gum. I told you I'd dumb it down, right? Okay, no. Around the root, there is a periodontal ligament that holds the tooth to the bone, right? What's above the periodontal ligament? The epithelial attachment, right? So that epithelial attachment, it's just like a seal around the tooth. And if plaque sets up, and then it calcifies, it can break that seal, and then the bugs. And I was a microbiology major at the Ohio State University, and if the bugs penetrate that seal, you get pus in the blood, right? There was another seal that failed on the Challenger. Do you remember what happened? Anybody? Does anybody remember with the Challenger space shuttle? What happened when that? You do. What happened when that seal failed? It blew up. Exactly. Okay. Now, dental anatomy 101. Okay, so we learned from Dr. Jazanavicius. Is that a cool name or what? But we learned a lot about tooth contour. We learned the difference between a central incisor and a lateral incisor. We waxed. Do you guys wax? Oh my gosh, spend time. Really listen to what she is teaching you, because if we take to heart what she teaches us, we can create beautiful, reconstruct porcelain teeth that look natural, cosmetic, aesthetic, wonderful. And if we fall asleep in our lecture, and we don't pay attention and don't take the wax up seriously, what are we going to get? We're going to get a piano keyboard. Okay? And there's a saying, you only see what you know. So if you don't take to heart what she said, you're not going to be able to tell the difference between a piano keyboard and beautiful, natural-looking teeth. Okay? Does that make sense? Okay, so Michael, I'm going to give you some proof on this. So Michelangelo spent the wee hours of the morning cutting up on cadavers without people knowing about it. But he learned, the bicep has two strands, right? That's why if you're able to go to France and go to the Louvre and see David, he looks real. He looks like, oh my gosh. But, again, he knew anatomy. He studied it. And so I really recommend that you take Dr. Jazanavicius' course seriously. Okay? Does that sound good? Okay, so now we've talked a little bit about the tooth contour. Now we're going to talk about the inside of the tooth. Okay? So up here is the enamel, right? Non-living, non-vital, and the tooth is an amazing piece of anatomy because we transcend from the enamel through the dent, becoming alive, to what's in here. It's alive, right? We have 3 pieces of anatomy. What are they? Nerve, vein, artery, right? If with periodontal disease, the disease goes through the periodontal ligament to the apex, what happens? The tooth dies, right? We get pus, right? Decay goes through the enamel, touch the nerve. What happens? We get pus, right? Let's take, for instance, let's pretend this is a virgin tooth. No decay, no restoration. It cracks. The crack goes to the nerve. What do we get? We end up with pus. Say it's the tooth's been endodontically treated, and a lot of endodontically teeth crack. And then what do we get at the end of the apex or where the crack is? Wherever the crack is, we get pus, right? So, and we really need to educate people in the healthcare about this, because if a tooth cracks, if an endodontically tooth cracks, do you think people are aware? No. How do they find out about it? From routine continuing care visits in a dental office, routine x-rays. That's what needs. So somebody, they could have immaculate home care, but if they crack a tooth or whatever, sometimes it can only be diagnosed with an x-ray, right? So as dentists, when we work on the top of the tooth and the non-vital and the enamel, what are we? Bricklayers. If we treat the inflamed gum, if we treat the inflamed tooth, what are we? We're doctors. Okay? I think it's time for another slide, don't you think? We've been on that one a long time. And I have 95 slides. You had the whole afternoon off, right? Okay, good. I'm going to have to start talking a lot faster. Okay, I can do that, I think. Okay, original Star Trek series. Any Star Trek fans here? Okay, all right. So anyway, back in the 60s, I'm watching an episode. My dad's behind me on the couch. He said, "Why are you watching that garbage? That's never going to happen." Captain Kirk's talking on his flip phone to the Scotty up there. And he says, "There's no cord there. That's impossible." Well, like Elon Musk wants people on Mars in 20 years. That's probably going to happen. But anyway, in this episode, it's about a Horta. See if that pointer. There we go. On the outside shows completely non-living, non-vital, and they see the phaser gun there. They shoot it, hurt it, and then Spock does the mind meld and realizes that there's somebody living on the inside. Does that remind you of something that I've just talked about? Gene Roddenberry was the creator, a brilliant person. But here we go.
You can't be serious. The thing is virtually made out of stone. Help it. Treat it. I'm a doctor, not a bricklayer. You're a healer. There's a patient. That's an order. Except for one thing. The Horta is badly wounded. It may die. It won't die. By golly, Jim, I'm beginning to think I can cure a rainy day. Can you help? Helped it? I cured it. How? Well, I had the ship beam down 100 pounds of that thermoconcrete. You know, the kind we use to build emergency shelters out of? It's mostly silicone. So I just troweled it into the wound, and it'll act like a bandage until it heals.
Okay, so as dentists, if we can control inflammation, infection, and pus through periodontal therapy, endodontic therapy, restorative dentistry, we can save lives. Now I'm going to talk about those 8 patients. The first 7 becoming overwhelmed with infection. Let's go back 25 years ago. I walk in the operatory. I see a patient there that's had a knee replacement. And orthopedic surgeon, my brother was one. They've been doing knee replacements for decades. And the guy says, "Oh, this is 3 months later. My knee's now infected. No one knows why." I'm looking at his panographic film. Back then, of course, 25 years ago, it wasn't digital. Otherwise, I'd have it in this presentation. But I look at that pan, I see multiple dental infections. And in the back of my head, I'm thinking, dude, I know why your knee's infected. Well, actually, the word dude wasn't invented back then. But anyway, so let's fast forward to today. About a couple months ago, I entered the treatment room, and this gentleman I played tennis with years ago, but his wife's a radiation oncologist. And he told me, my wife wanted me to share this story about a patient she treated, and I called his wife that night to verify the information that he told me. But he basically said his wife was supposed to irradiate a trigeminal neuralgia. Has anybody had any experience with somebody with trigeminal neuralgia? You have? Okay. So basically, it's very painful. And I had another patient about a year ago that I did Botox on, here and here, to relieve his pain, because any touch fires the nerve. So the solution for this guy ultimately was he had a neurosurgeon separate the artery from the nerve. Every time the artery pulsated, it could fire the nerve. And that solved this problem. But he gave me one of the nicest thank you notes I've ever received. And just taking him out, taking care of his pain. But back to my patient's wife. She did an examination, looked in the mouth, found a huge tongue full of squamous cell carcinoma. Okay? So, and now I'm really pounding home about that wall that's there. So, in other words, he went to a primary care doc. She didn't look in the mouth. Referred to a neurologist. He didn't look in the mouth. Then referred to irradiate the nerve. And the problem of what was causing the trigeminal neuralgia was the squamous cell carcinoma in the tongue. Okay? My neighbor had a kidney transplant from his son years ago, immunocompromised at this point, and I wanted to dot my I's, cross my T's, so I talked to his concierge nephrologist, who doesn't take insurance. My neighbor can afford her because he's a billionaire. But anyway, I talked to her, and she said, I feel like 80% of the kidney infections and problems are a result of oral or anal. So I guess I'm not a big proponent of telemedicine, right? I mean, if all you're looking at is blood work, you're going to miss a squamous cell carcinoma, right? You're going to miss a dental infection. The white blood cell count's going to be out of whack and everything. But and then I am scheduling a presentation similar to this one to the Hygiene Association about 9 months ago, and I'm talking to the receptionist, and she asked, "What's your topic?" And I said, "Well, dental inflammation can kill you." She said, "You're kidding." She said, "My sister needs her heart valve replaced, and they've determined that it's a dental infection." So this is Lisa. She came to me, and she said she's dying. There's nothing that can be done at the hospital. She wants me to remove her teeth, and you can see, probably a lot of pus sacs above those teeth. She just doesn't want to die in pain, so she wants me to take her teeth out. And they wouldn't take her teeth out at the hospital because the risks were too great, because her heart ejection fraction is only 28%. Okay? Well, back in 2008 when I did this, I had a lot more testosterone than I have today. I hope that doesn't offend the women in the room. Wait a minute. Trump's going to be president. I guess I can say whatever I want now? Okay, I got some laughs. Okay. Well, okay, if I can, okay, fine. Well, anyway, we as men, we have a brain and we have a penis, but the problem is we only have enough blood to power one at a time. And that, that was like a Dean DeMarco, right? Yeah. I did, when I was in dental school, I did get brain damage, so pardon me. Okay, now back to Lisa, okay? So I took her teeth out, and a few are laughing. I said I might be thrown out of this place, but okay, I got to talk fast before you throw me out. Anyway, this is Lisa. So you can see a lot of gum disease in this area. Severe periodontal disease, broken off, took out all the teeth, and then a few months later, she sent me this letter. She said, "Dear Dr. Marxen, I'm so sorry for the delay in making payments to you. I ran into a bit of financial hardship for the past few months, but I'm now back on my feet. I promise to pay a minimum of $100 per month with every effort to make larger payments each time." Well, I never got paid. She declared bankruptcy, and as Dean DeMarco would say, you know, no good deed goes unpunished. But no, it made it all worthwhile. The second paragraph. "I also want to take a moment to tell you how grateful I am that you are willing to do this work without full payment due to my health situation. It is because of your generosity that my health condition has improved dramatically. Before the dental work, my ejection fraction was 28%, and my prognosis was not good. A few months after the procedure, my ejection fraction has increased to 40%. I wholeheartedly believe that you have saved my life, and I'm forever grateful for you for that. Thank you for your patience, generosity, and willingness to do this work with me." So after receiving this letter, I drew a conclusion. Wow, dental infection can cause heart disease. Would you draw the same conclusion? Okay, so next patient, Lisa. Lisa again. Are there any Lisas in the room? No? And no one laughed at that one. That was bad. Okay. Lisa, look at her facial complexion. She doesn't look healthy. Do you agree? Why doesn't she look healthy? At this point, she's got a 6-figure income. She wants a full mouth reconstruction. She wants the best. She wants a full meal deal. She has recovered. She's been clean and sober for 6 years. And a lot of addicts are very, very bright. They're very smart. So if they can recover, they can get 6-figure income jobs. And that's what she had. So here's her pan. What do you see here? That's like a hole, right, in the maxilla? What do you think that hole is filled with? Guess. Pus. Exactly. So there's nothing that can be saved on top. That's an upper immediate denture, right? And maybe we can save some of the teeth on the bottom. So I get her set up for an immediate denture. I'm going to remove the upper teeth and most of the lower teeth. And I get a call from a brain surgeon. Brain surgeon? Why would I get a call from a brain? And the hematologist is on the phone at the same time. And they're telling me, brain surgeon says, I think before I repair her aneurysm, you should remove her teeth. And I said, I think that's a good idea. And the hematologist is saying, do you want me to remove her off the anti-coag therapy? She's on Eliquis, she's on aspirin. And I said, no, I'd rather her bleed than have a third stroke in my office, thank you. The fire department across the street, they've got lots of blood. So let's go back. Let's think about this. Okay, she's had two, I'm providing evidence for that big, big wall that we're trying to break down here at Case Western, right? So she's had 2 strokes. So what happens when you have a stroke? Where do you go? You go to the ER, right? That's where you're going to go first. So what's anybody do any ACLS training or whatever, or CPRU? What's the acronym for, it's FAST, right? F-A-S-T. For a stroke, that's your acronym. F, face, droops. A, arm. They can't move their arm. S, speech. They start slurring their word, or they can't speak at all. And T, time. It's critical that you get them to the hospital ASAP, right? Because they're going to do a CT scan. And what are they going to evaluate? Is it a clot? And if it's a clot, anti-coag therapy, or is it an aneurysm? You don't want to give them anti-coag therapy if it's an aneurysm, right? So basically, she's gone to the ER twice, and she's told them, I have a dental infection. It goes right over the ER doc's head, right? It was the brain surgeon that figured out maybe there's a connection. That's the reason he's a brain surgeon, right? Okay, so We took out her teeth. And when I take out teeth, typically I draw blood for PRF, platelet-rich fibrin. So that's second generation. PRP, a lot of the med spas, they're still advertising, they're still doing injections with that. That's old school. With PRP, platelet-rich plasma, you're putting anticoags in the blood before you spin it. With PRF, which is what this is, spinning the blood, you're snipping off the white blood cells, red blood cells to get these growth factor membranes, which you can see, right here. Then the lid flattens them out. So this is second generation. Actually, I've injected my shoulder. I was with an orthopedic surgeon. I had a consult that said I'd need surgery. I think my shoulder working pretty good, huh? I've done my knee too. A sports med doc did PRP on my knee 20 years ago. Dentistry's version at that time was PRGF by Eduardo Anitua in Spain. Now, PRF. The next generation is exosomes. Does anybody know what an exosome is? Raise your hand. Holy smokes. That's where all the research is being done on exosomes. They're the tiny vesicles that make the cells communicate with each other. But that's the next generation. They're even looking at exosomes to treat Parkinson's disease. It's going to be, right now the FDA has approved exosomes for hair and skin. Actually, I have a product in my office now that has exosomes for skin. But anyway, so we're going to flatten these membranes out. And we're back to Lisa. We're going to be putting the membranes in the concavity. So because she's on these anticoags, right, I didn't have her remove. I didn't lay any flaps. I didn't cut any vertical incisions. I wanted to remove the teeth as least invasively as possible, right? So my dental assistant and I, we scooped all, there we go. I got to get used to this. This isn't mine. I'm not used to it. Anyways, pardon me. But anyway, we cleaned out that concavity in her sinus, all that pus, granulation tissue. I spent 30 minutes on that. And after that, after we were done, my receptionist walked by the room and she said, "That room smells like a cesspool." And I said, "Elizabeth, that's impossible. We're not in Michigan." Okay. Try. Okay, so this is the video that I sent a brain surgeon.
Okay, Lisa did really, really well. Has clotted very well. Removed all the cysts from the sinus area. A huge concavity from the incisal foramen to the facial plate. And then we're going to place in there these PRF membranes we got from her blood, stem cell membranes. And these are the cysts that we removed that we're going to biopsy. And this is her smile.
There you go. So we placed, these are the membranes that are in place. You can see them right here. And the PRF membranes, they're anti-inflammatory and antimicrobial. So the healing's faster, the healing's more comfortable. We'll talk more about those in a little bit. But then this is exactly what you would expect after they're biopsied, consistent with apical radicular cysts with active inflammation. No evidence of malignancy. Okay? So now, I always see the immediate denture patient the day after. This is the day after visit. We gave her flowers. Notice her color is much better. She feels better. I mean, you saw all the infection in her mouth. Do you think at this point she needs to be on anticoag therapy? What do you think? No. Exactly. Okay? And that's about a couple months later, a new pan. You can see the bones already filling in. We were able to save 4 teeth. Okay, so more evidence for that wall between dentistry and medicine. You're not going to believe what this guy is. And I'm going to ask you in a minute. But anyway, he comes in with a friendly tooth. He breathes out, it's waving to you. Breathe in, breathe out, breathe in. Okay, and he, again, I remember I learned from Dean DeMarco, you pretend like you got $1 million in the bank, right? Because he says, he only lets me take this one little PA, and he only wants that one tooth removed. And I told him, you know what, if you just want me to remove that one tooth, I won't do that, you can go someplace else. And I think there's other teeth involved, but if I remove that one tooth, you're going to end up with a stroke. So he elected to let me take a pan. And you can see infection here involving 3 of the teeth. I took out 4 of the teeth. Here's the pus sac around the upper second molar. Here's the pus sacs that were on the bottom. I have my thumb there so you can see how big they were. But then put PRF membranes in those areas. So what do you think he is? Guess what he does. What's his profession? Take some guesses. He's an MD. What kind? What kind? Huh? Okay, I'll just tell you. He's a hematologist. He's an expert in the blood. And he's got pus. So the head, especially the maxilla, it's so vascular. It's literally like injecting pus right in the vein, right? It goes throughout the body. So he's not a clinical hematologist. He's retired. He used to work for Amgen. Actually, I'm on a drug from Amgen right now. Lowers LDL. I have, atherosclerosis or whatever. So, Amgen's done a lot of great things and everything. But that just shows you, how, again, he's an MD, he's a blood specialist, and he's got dental disease and pus in his blood. Am I giving evidence about that wall? Am I doing a good job with that, you think? Yeah? Okay. Okay, so another guy he comes in, wants me to repair some plastic gums that broke. And you can see, Naomi didn't place these implants, right? And you know what? I think my chocolate lab could have done a better job. She's got really good hand skills, right? But back to this, and then you can see pus halfway down that implant. Can you see that? Here, peri-implantitis. But a lot of these dental implant centers, they give you one choice, 4 implants, that's it. They don't give you any other option. They charge $28,000 to $34,000, and they're all different. I think their standards there, like this is like West Virginia. Jethro comes in, he says, yeah, this thing is got to get sore. The dentist will say, well, Jethro, you took 5 years to get that far. You got another good 5 years for you. You got to replace that thing. Actually, my family's from West Virginia originally, my great-grandfather, but my grandfather then moved out of Ohio because he wanted to marry somebody other than a relative. But true. Then we came to Ohio, they called us hillbillies. That put the big chip on the Marxen shoulder that, we're not good enough or, whatever. So my grandma had to be valedictorian. My dad had to be a general surgeon. But anyway. Yeah, and you can see there's no way they can clean this. You see all the plastic here? Holy crap. There's no way. And there's going to be a big class action lawsuit. It's coming. It's already public. But the details aren't. But you're going to see cases like this. You're going to see attorneys on this. If you had an all-on-4, then call 1-800 all-on-4 goes to crap. Right? That's coming, believe me. And the details will be there. And they're going to be, when you have somebody that's wealthy that knows a really good attorney, oh boy. Yeah, so that's what's coming up. But again, they charge $28,000 to $34,000 per arch. That one of these dental implant companies, they made $90 million in profit net a year. So bought them. But again, are they going to assume the liability of the dental implant? You know what I mean? I don't know about that, but I want to stay away from this. Boy, If I were a prosthodontist coming out of school, I certainly would not want to employ at one of these dental implant centers. But anyway, they only give you, they don't give, so in this case, why not just include another implant and put them where the teeth are supposed to be, like let Yomi do it, right? There, look at that. This is Cheryl. So, and you know, what they call this now is a 3-on-6. So you've got an implant, you've got a bridge here, one there, and one there. And the implants are placed where they're supposed to be teeth. So this is a video of what we do at Advanced Care Dentistry versus what one of those dental implant centers do. Bam.
This is Cheryl, after replacing her uncomfortable, unstable plastic denture implants with new, natural, high-quality implants at Advanced Care Dentistry. So what's the biggest difference in her mouth?
No plastic.
No plastic. It's so nice to not have my mouth full of plastic. And that they feel so real. And it's just, it's really going to be life-changing. I'm going to have to learn how to smile again.
Several million Americans have dentures, or they have implants supported with dentures in their mouth, and all this plastic is still present, which traps food, which stains, discolors. It's uncomfortable. A lot of patients just get used to it, and they don't understand that there's another option, there's another choice, and that would be place 2 more implants, and then you can make 3 bridges on top, 3 bridges on the bottom, and completely eliminate the plastic and the porcelain.
So I feel like I've been kind of released from that prison, of all that stuff in my mouth. And the movement from the lower one, it's just, it's huge.
You won't see Dr. Marxen installing plastic dentures in the patient's mouths. Instead, these new porcelain implants grow naturally.
You can see the natural gum tissue
that's been rejuvenated,
and the porcelain just rests on it.
Therapy.
Because we want the best cosmetic effect, we want the best function, we use the highest quality porcelain, we use ankylose implants, which are the strongest, the best implants.
Another Advanced Care advantage, your implants are secured at 6 critical spots in your mouth. Most competitors use only 4.
When the person smiles, all you see are beautiful porcelain teeth.
Now you've got a better choice in implants. Make the natural choice at Advanced Care Dentistry.
Okay, so I personally feel like a lot of the implants that are placed today, they start their lives out infected with peri-implantitis. Like I would never place I'm not a big immediate placement person because I think a lot of the implants, never put an implant in an infected site. It's starting its life out infected. So typically, I like the ankylose implant because the top, and they're not paying me any money to say this, I'll give you that disclaimer, but top of it's coated, so you can place it subcrustally and then the bone can grow over the top of it. But when I place implants, I keep the site isolated and then put a PRF membrane. I cut it into like a third, and then place this healing abutment through the membrane, which forms a seal, then screw it into the implant, and then tuck the remaining portion of the PRF membrane under the gum tissue. So it basically starts its life out in a sterile environment. And it can osseointegrate in a sterile environment with the PRF membrane. Plus it helps the healing too. It's antimicrobial, anti-inflammatory. So I decided, I'm just going to chat GPT. Can an infected dental implant cause a stroke? Well, it's rare. Well, chat GPT, it's great for some things, but I think this is behind the times. This is saying it's got to become a bacterial endocarditis first. It's got to come from the heart, right? Okay. This person comes in, and she's a successful realtor in Seattle. She's good friends with my sister-in-law that's a mortgage broker. They know the families really well. Her complaint is This central is longer than the other central, and it's slightly rotated. Okay, for those dental students, why is this tooth longer? See if you can shout out the answer. Why is this tooth longer? Why is it rotated? Huh? It's pus, right? It's pushy. It's pushy pus. It's yeah. Yeah, I'm sorry. I told you I'd say random things, right? Okay, that's what's pushing it down. Yeah. So I took a full scan on her, and you can see here that molar's sitting in pus, right? And then I talked to her about everything that I've said from the beginning of this presentation till now. I explained to her this could be life-threatening, could be this and that. So anyway, that's case 7. So do you think on all these cases that I presented, did anybody die? Raise your hand if you think somebody did. This person died. Yep. She blew me off, didn't want to hear what I had to say, and I mean, she was concerned cosmetically. I don't think she cared much about her breath, but because someone with this amount of severe periodontitis, typically they don't have the greatest breath in the world, right? So I saw this patient about 1.5 years ago, and then it was a year that my sister-in-law told me she died. Okay? What did she die of? Take some guesses. You shout it out. A stroke? No. What did she die of? Dental disease? No. What did she die of? Sepsis. Sepsis. Was the sepsis, did they say it came from the mouth? No. Where did it come from? The liver, right? There were 2 infections in her liver, okay? But the mouth, so, and then my wife's an MD, and there's no barrier, there's no wall. The barrier, I broke that one on our honeymoon. Finally, I get a laugh. Okay. I could never say that if she were here, and I hope the heck she... Anyway, so she did a PubMed research, and basically, maxillary infection in the maxilla can go to the liver, right? So did the hospital call me and say, oh, what about her? Do you think when they did her autopsy, do you think they opened her mouth? Did the hospital call me? What was her dental health history like? No, she died from infections in her liver. How'd that happen? Crap, I don't know. Right? This is the wall that we're not sharing information. Actually, the one patient was Lisa number 2, was at the hospital. So they're being careful now as a result of that case with the brain surgeon, right? So slowly, I think we're spreading the word. I think we're better off again at Case Western than some of these other schools. But I'm going to have to talk a crap a lot faster, okay? I'm going to, this is the one. This is, so I'm going to have to blow. I'm going to talk real fast. If I'm talking too fast, just let me know, but we got to go here. So Nicole said she's a 34-year-old female. She was referred by a general dentist for an all-on-4 so that she could get a job as a dental assistant. The general dentist, she went to the general dentist church, and 4 congregational members contributed to her treatment. You know, if she were referred for an all-on-4, what would they do? They'd take all her teeth out. They'd whack away all this bone. Why would they do that? So that you wouldn't see the transition between the plastic gums and her natural gum tissue. It'd be up above her lip. You wouldn't see it, right? That's what they would do. So she's only missing 4 teeth. So in my mind, I'm thinking, well, why don't we just put in 4 implants and save the natural tooth? So when I published this case, I wanted to call the article All on 4 or Go Natural on 4, making the right decision difficult. Well, the editor, he didn't go for that title. This is what he chose. That's not very sexy to me. Decision, you know. Okay, so the case did involve multiple disciplines of dentistry, including myofunctional therapy and social conditions that contributed to an extended treatment time. The path selected to get the successful outcome made it one of the most difficult cases I've treated since finishing the grad program in 1985. It was technically difficult and extremely risky considering the behavior changes required and the coordination of all disciplines for long-term success. I had failures and obstacles to overcome along the way, but nothing like recovering from 7 broken ribs and a tension pneumothorax in the hospital. See, I got back there. That wasn't quite so random. But anyway, let's look at Nicole. I don't know if anybody's experienced something with bulimia. That's classic in the anterior. I'm going to go back a little bit and talk a little bit more about Nicole. Her father was an international drug dealer. Teenage boy told her that she was fat. I told her, next time someone tells you that, tell them they're ugly and you can go on a diet. But she recovered from bulimia, and then she got anorexia nervosa. And then she became addicted to meth. And a lot of women that become addicted to meth get pregnant. That happened. She recovered, relaxed, recovered several times. And then I mentioned before, evidence of bulimia here, lots of decay everywhere, evidence of meth, evidence of altered passive eruption in the maxillary. The entire maxillary dental gingival complex actively erupted to replace the missing tooth structure in order to maintain vertical dimension with a normal freeway space. You can see her face is a little bit dished in here because obviously lack of anterior tooth support. The missing tooth 2, 5, 18, 30. The altered tooth position and the splaying of the anterior teeth are definitely as a result of a tongue thrust. Okay? In the next video, I want you to really focus on her tongue. Okay, here it comes.
Yeah, I mean, I never thought that have a nice smile that I could be proud of. Like after the dentist last year told me, you know, yeah, no, we can't do any temporary work. It has to be permanent. And I was like, oh my gosh, okay, pull them. And he was like, no, you can't pull healthy teeth. And I was like, oh, my teeth. So can you just give me dentures?
Okay, at this time, I wanted to identify as a snake. Okay, yeah, thank you. I got a little laugh there. Okay. So, case was mounted on a Panadent articulator. Treatment began 6 months after initial evaluation, so that we began 6 months after initial evaluation with a full set of diagnostic records in order to evaluate if a sustained recovery was possible. Her medical status is stable. She has gingivitis, but no evidence of periodontitis. Caring for her 11-year-old son as a single parent is giving her incentive to not relapse. Excuse the basketball analogy here. My daughter played for University of Idaho. The Vandals, they won the Big Sky that year. Is there somebody in the room that doesn't know anything about basketball? Raise your hand. You don't know? Okay. So in basketball, if you get 5 fouls, you're out. You can't play. You're done. You're on the bench. Okay? So this case reminded me of starting a basketball game with 4 fouls. Right? First foul, she recovers from bulimia. Second foul, she recovers from anorexia nervosa. Third foul, she recovers from meth. How many can do that? Fourth foul, she's got to do the myofunctional therapy for speaking, swallowing. Fifth foul, she's allergic to anesthetic, local anesthetic. No, I'm just kidding. Okay, but we have to remember, we can't IV sedate her for the surgery. We can't give her any opioids. And so, yeah, and if we're going to avoid an immediate denture on all-on-4, there's some considerations. First of all, will extensive invasive treatment cause an addiction relapse? That's certainly a concern. Can the natural teeth be saved? We know we've got a lot of decay on the anterior teeth, decay here. And thirdly, is it possible to do crown lengthening with acceptable crown to root ratio? Well, fortunately, she's got long tapered roots that are just long, slightly tapered. But again, if she were at one of those dental implant centers, they'd remove all those teeth and they'd whack away all that bone. It would be gone. Like that professional term, whack away? Okay, is it possible to do crown lengthening with acceptable crown to root ratio? Well, we'll do a surgical splint to make that determination. Can we remove enough bone so that we not end up with a gummy smile? And that surgical that we'll make will help us, and we'll make that from the diagnostic wax-up. And then last question, is there enough bone to replace 4 missing teeth with implants? Clearly, there's enough vertical bone, and then the CT revealed there's enough bone from a facial to a lingual standpoint too. I'm going to even talk faster because we want to get out of here. The wax-up was done. It's a little over-contoured there, too much overjet. The model from the wax-up. Okay, if this stent's in place, we need more apical lengthening above 6 and 7. New stent done. Okay, now we put it in her mouth. We could still use another millimeter of lengthening above 6 and 7. I just remembered to do that at the time of surgery. So that's a full thickness mucogingival flapless reflected from ear to ear. And you can see, now we're going to compare before bone removal to after bone removal. So remember, we needed another millimeter above that 6 and 7, but you can see crop load of bone removed. It's time to prepare the teeth. So you prepare the teeth, and you want the finish line to be at least 2 to 3 millimeters above the bony crest, because you want a healthy biologic width, right? So then you're going to load the tray with provisional material. You're going to make a provisional, and she has teeth. Yay, she's excited. She's jacked. She hasn't relapsed. She hasn't crashed. Oh, she's all excited. So this is a 4-day post-op. Pretty good adaptation to the implant abutment. And it looks like the papillas are going to be fairly healthy. Here we go. Okay, so when I sent this to the reviewers for publication, one of the reviewers said, "How long did you leave her like that?" How long did I leave her like that? Yeah, that sucks, I know. I mean, these teeth, the axial inclinations point to her shoulder, not her navel. The teeth are too long, they bury into her lip. But you have to realize, I mean, after removing 4 millimeters of bone, how long does it take the gum to mature? Months, right? And then what about, she hasn't smiled for years. We've got to reactivate those smile muscles. So just to show you, watch this video, watch her upper lip. She almost looks like those Germans or the pictures that were taken back in the 30s and the 40s. But notice her upper lip here. She does not like to show teeth. She's got to retrain these smile muscles.
Give me a big smile. Pretend I give a great smile. You show a lot of gum tissue.
Okay? So we recontoured the provisional, shortened it, brought it in, changed the axial inclination, all those smile design line parameters. We wanted to meet those. And then this is the orthodontic S line. The lips are better balanced behind that. And of course, the reviewers always want pictures of your preparations. So you can see here, I only had this stock abutment, this implant, and the value is too high, the chrome is too low. So that's going to come back to bite us later on. I'll show you that. Anyway, so the upper arch is max that's pressed anterior layered. And typically when I'm designing full mouth reconstructions, I like the cuspid to be the lowest chroma value, the lowest value, highest chrome tooth in the mouth, sitting right next to the lateral incisor, which is the highest value, lowest chroma tooth in the mouth. And then the centrals are somewhat in between. All these subtle details, and if we learn the contours from Dr. J, these are the things that make the teeth look real natural and everything like that. So you can see we have an issue here, no papilla. We have to deal with that later. Okay, so now we're going to do the whole lower arch, and we did it in one day. We did resin to the anterior teeth to hold the vertical dimension while we did the posterior teeth at one time. Lined them, luted them the same day. Now it's time to do the lower anterior teeth. Okay? There's a lot of space between these two centrals, so we're going to place a deflection cord, and we're going to place the finish line right on top of that epithelial attachment so that we can have an emergence profile that's going to create a healthy papilla. So this is third generation Omnicam. First was red cam, blue cam, Omnicam. Now we have Prime Scan, and there's Prime Scan 2. But this is CEREC technology, and I've been doing it since red cam. But anyway, so we outlined the finish lines around the preparations. And I think a lot of the prosthodontists are dinosaurs, but in my opinion, but I did not want to be a dinosaur. So I'm doing PRF, and I'm getting into exosomes, but anyway, I want to be, like we have Yomi here, and and if you don't have Yomi, I could mount my chocolate lab. Okay, but anyway, so the CAD machine designed this, and I think Dr. J would say the contours are pretty good. So old school was you'd wax up. And I always learned, if you want the teeth to look natural and lifelike, you wax up the full contour. That's what that is. And then you cut back and you put in wear patterns according to that patient's age. Nicole's 34. So here you can see, I think there's not a lot of inflammation present there, right? I like the papilla because that was our toughest spot. And now we're going to deal with the no papilla, right? Okay, so I kind of got this. Miller published an article in the International Journal of Restorative Dentistry, Prosthodontics Restorative Dentistry, and he used this technique to augment a ridge. I'm going to use it. I'm going to kind of steal it, and I'm going to use it to augment a papilla. So first of all, we're going to thin layer of epithelium. We're going to reflect it back, and then lay a thin layer of connective tissue. Then we're going to roll that connective tissue up and hold it with a suspensory suture, this composite bar. That was kind of my idea, the composite bar. Glenn, who classified papillas, kind of this technique a little bit for just the contact point. But then we're going to place coronally position the epithelial flap, and then we're going to compress it with this retainer, which was used during the myofunctional therapy to help stabilize the teeth. And we learned from Frank Spear, who was Jack Love's classmate. Jack Love was my mentor when I was a dental student. He was in the grad program there, and he told me, get a scientific camera. So I started taking pictures as a dental student. We learned from Frank Spear that the papilla is like a water balloon. If you compress it in one place, it'll expand in another. And that shows you that the Holly bar from that retainer doesn't touch the composite bar there. And this is the resultant months later. I think we've got improvement there. So, to my knowledge, this is the only case published that compares Emax that's low battery. I got to hurry. I got a low battery. Okay. A little low battery. Okay. But anyway, this is, to my knowledge, it only compares the Emax that's pressed, anterior layered, lower is CAD design and milled same day. And Nicole is awesome. She is, thank you. Paul is awesome. The technology that he set up, he's the man. Thank you, sir. Okay, so Nicole, she's happy. considering so many people did a lot for her, like the lab, they did the lab work at no cost. Bellevue in Bellevue. Patterson Dental donated the blocks. Dentsply Sirona donated the implants. And she, considering all these things were done for her, she was not entitled. She showed up for all her appointments. She's still a successful dental assistant. She's worked at the same practice. And I wouldn't have her in my office because they have drugs, obviously. Yeah, she's done amazing things. So I'd like Dr. Roma Jazanova to compare the lower contours to the upper, the lower anteriors to the upper anteriors. I think with the CAD design, I think the lowers are, typically the labs over contour the lingual. I didn't mean to do that, okay? But look here. To me, the lab work, the gingival embrasures and the lingual are over contoured. Okay? So, but you can tell that I'm into minimally invasive dentistry because this number 32 just has a resin. Did somebody laugh? Okay. Thank you. Okay, so anyway, this is that higher valued abutment. You can see that too, it's a little bit higher in value. But I think we've cured inflammation. Do you think? We've controlled it? Good. And then this is the pan before, after. So 9 root canals, 4 implants, 14 EMAX pressed anterior layered restorations on top, 15 CAD design milled same day restorations on the bottom. And my niece did her hair and did her makeup to get the glamour picture. And this is the final video.
I'm self-conscious to talk to people. In my mind, they're thinking, wow, look at that girl with her teeth missing or half broken. I graduated from dental assisting school, and I put all that time and effort into graduating. I wanted to utilize that degree. No dentist is gonna hire me. My teeth messed up like this. I just kind of let that dream go. I figured I'm gonna end up working at McDonald's or something, but you know what? I'm gonna share my story at church.
I mean, it happened on my birthday too. They called me and she goes, "You'll never believe it." I'm like, "What?" She goes, "Somebody wants to help you fix your teeth." I was like, "Are you serious?" I thought she was joking. I never in a million years would have thought this was possible. And that just shows me how real God is. Honestly, I don't really have any regrets because even though I made poor choices, it got me to where I'm at today. And I don't believe I'd be at where I'm at today spiritually and in any way if I wouldn't have made the poor choices in my life. It just makes me who I am today. When patients come in now and they're talking about, oh, getting worried because they have to get a root canal or they have to get a tooth. I was like, no, that's not even, I thought it was scary at first too. I can actually relate to them. God sent you to me and me to you. I'm grateful for you.
Thank you. Questions? Pardon? I think we're running over time, so we're gonna... Okay, no questions. Right. Okay, that's great. I'm happy about that.
Thank you, Dr. Marxen. Give him another hand. Wonderful. On behalf of the faculty, students, and staff here at CWRU, we thank you for sharing your time, expertise, and experiences with us today. We have no doubts that your experiences, both the triumphs and the challenges, will resonate with our students, motivating them to pursue their own path with the same level of commitment which you have shown. As a small token of our appreciation for your time, effort, and the invaluable contribution to our community, I am honored to present you this gift. We hope it serves as a reminder with our connection with you, to this university, and the lasting impact you've made on our students and faculty alike. Why don't you come up and...
Wow. Wow. Thank you. Thank you. Wow. Thank you.
Please join me in showing our appreciation for Dr. Marxen, and please join us outside in the South Winter Garden for lunch. Thank you again.
Thank you. Yeah, thank you. Thank you.